Welcome, everybody. Today, we are going to find out if you can rewire your migraine pain non-pharmacologically, and if so, how. We're going to be learning from two esteemed medical doctors today, each of whom is brain expert with their own distinct specialty. So I'm going to let them introduce themselves so we can get the ball rolling here. Why don't we start with you, Dr. Lowe?
Hi, everyone. I'm Dr. Jessica Lowe. I am a neurologist and an epileptologist, which means that I have completed medical school and my residency training in general neurology, and then went on to do additional year of training in epilepsy. Fun fact, I also suffer from migraines. So I have a unique perspective in that I am a physician who treats migraines, but I am also a patient who suffers from the disorder. So I do bring that unique perspective to the table. And yeah, I'm excited to do some learning with you guys today.
So that means, Dr. Lowe, that you like your doctor because it's you, right? That's
It's actually not me.
not you. Okay.
Although I do have the perspective where I will oftentimes, they are my colleagues, so I
Sure.
will reach out to them and say, "Hey, can we try this thing?" So
That's good.
that is a bit unique and works to my advantage, but that's also a complex relationship that you have to maneuver to maintain that patient-physician respect and dynamic.
Yes, indeed. Yeah, well, I'm Dr. David Spiegel. I'm a professor and associate chair of psychiatry and behavioral sciences at Stanford University. I've been studying the brain and hypnosis for almost 50 years. I do studies of the neuroimaging of what happens in hypnosis. I've used hypnosis personally with about 7,000 patients in my career, which is why I'm so tired right now. And I enjoy using it. And we have lately built an app called Rewiring that I'll tell you more about that teaches people how to use self-hypnosis for all kinds of problems, including migraines.
Dr. Lowe, can you kind of share with us what it's like to live with a migraine and what is the neurobiology behind it?
Yeah. So, I think it's important to distinguish that migraine is not just another headache. There are over 200 types of headaches, and they have been well characterized by the International Headache Society. We do have very specific diagnostic criteria for each of those headaches. So, a migraine is not just a bad headache, it does have a unique pathophysiology associated with it. And that is what creates the exquisite pain that is often associated with it, but also helps us have a unique treatment approach when managing it. So to kind of get into the objective data, how we diagnose migraine, you have to have what is considered a recurrent headache disorder. Attacks have to last between 4 and 72 hours, and they have to fulfill very specific criteria, one of which is the time, right? So, like I said, attacks lasting 4 to 72 hours. They have to have at least two of four characteristics, including a unilateral location, meaning on one side, a pulsating quality, which is that pounding, throbbing pain, moderate to severe pain intensity, and aggravation by or causing avoidance of routine physical activity. And that's a big one, right? Because that's where we get into the disabling nature of this disorder. And then during the headaches, you can have at least one of either nausea and or vomiting or sensitivity to light or sound. So as a physician, when someone comes in to see me to say, "Hey, I'm having headaches," that could mean, like I said, 200 different types of things. So when we start talking about migraine, which is one of the most common headache disorders that we see, these are the criteria that I go through to say, okay, is this actually a migraine? Because making sure you have the right diagnosis is key to making sure that you are treating it appropriately. Now, the pathophysiology of migraine, like I said, is quite complex. And I've done videos about this on social media where I really get into it. But the overall theme is that you have something called the trigeminovascular system, right? Which is nerves and vessels in the head. Okay. And what essentially happens in patients with migraines is you have an activation of a part of the brain called the hypothalamus that kind of starts to slowly activate this trigeminovascular system. And what happens is you end up creating what is called an aura, which is where the brain itself kind of gets this wave of activity, this gross activation that moves over the brain. And that activation activates those nerves and vessels so that they become hypersensitive, right? So patients are very sensitive to pretty much everything, right? Light, sound, smell, right? Even touch, to the point where something that shouldn't be painful ends up being painful. If you're in the middle of a migraine and you kind of just run your hand through your hair, feels like, knives sometimes, right? And so there's this gross sensitization of everything in the head and neck. And that is perceived as sensitivity to multiple stimuli around you and a sensitivity to pain. And that is what creates that very exquisite pain that we see with migraines. And you can imagine, having described that in a, kind of a simplified version, that if you're having horrible pain that you can't even rest your head on a pillow or brush your hair back, you're probably not going to want to get out of bed and do a whole lot. You're not going to want to feed your dogs, get your kids ready for school, drive to work. And a lot of patients with migraines, most patients with migraines, are unable to do those things, which then brings in that component of the disability associated with it, right? Now, with migraine, we have patients that, they'll get a migraine once a month. And like I said, it can last up to 72 hours. So they're out for 3 days, right? And then they're fine. Okay. And, we kind of make accommodations for those 3 days, and then we go on with our lives until the next month. But there are patients that have chronic migraine. And that means they're having those migraine attacks 15 times a month. And if with each of those attacks, they're lasting 1 to 3 days, well, how are these individuals able to function, right? And so this is where we really get into that disabling component of migraine and how it's often perceived as, oh, it's just a headache. Why can't you just function normally? No, it's not just a headache. And it is, in fact, a very disabling disorder to have if it is untreated or not appropriately treated. And then we can get into how we're going to do that later on. But this is what it's important to understand with having a migraine or being diagnosed with migraines and migraine disorder, is that as the frequency of migraines increase, if you're a person that has one a month or one every couple of months, okay, we can probably manage that. But if you're a person that's having very frequent migraines, this is where, it really starts to have that very dramatic impact on your life. And as a physician with migraines, you can imagine that is difficult, as anyone with migraines, really. But for me, as a person who suffers from migraines, like I mentioned to you guys before we jumped on here, I started having them in residency, which is impossible. It was terrible, because as a resident, you are chronically sleep deprived. You're awake for 28 hours at a time. You get 4 days off a month. The time that you have off, you're studying. And that is very difficult when you're dealing with something that is essentially a chronic pain issue, right? And then that introduces the component of, will you start treating it so that you can function as a resident and then a fellow? And the medications make you sleepy or give you brain fog or word finding difficulty, which of course does not work well for someone who's supposed to be studying and performing and is being evaluated by physicians and who is also making life, hopefully saving decisions, of course, supervised. But it was a very difficult time as a resident dealing with migraines and the side effects of medications and whatnot. As an attending physician now, I am fortunate to have more flexibility in my schedule. So if I need to go in a little later on a day, I can do that because I have a migraine and cannot see to drive on the highway to get to the hospital. But not everyone has that ability with their job, or with their day-to-day life. And so these are the things that, as a physician, when I have a patient who is suffering from migraines and is coming to see me, especially if they have very frequent migraines, that we have to think about and work around. We want to treat the migraine itself, but we also have to consider the very dramatic effects and impacts that it has on that person's life. And, how do we work around that? How do we accommodate that?
Lots to unpack there. Thank you. Was there anything else that you wanted to mention about triggers?
Yeah. So, kind of just speaking to the treatment of migraines, right? We have, and this is what I tell patients, when you're dealing with a painful disorder, you have the objective components and then you have the subjective component, right? The objective component is the data, the science. I can explain to you, okay, this part of the brain activates this part of the brain, which activates this part of the brain. I can explain to you the data from the studies of why medications work, which percentage of patients find success with these medications, things like that. But, as we are often taught in medical school, residency, fellowship, patients are not textbooks, right? So, and we don't know everything yet, right? We're constantly learning, we're constantly getting new data, we're constantly finding out new components of disease processes, especially in neurology, where it is such a complex organ system. And, there are things that we just haven't pieced together yet. So the objective data will take us so far, okay? And the objective data, of course, helps me select what we're going to do in terms of medication and managing these medications. But the other component is the subjective part of it, right? And that subjective part is what the patient experiences, what their potential triggers are versus another patient's triggers, right? Because as I've explained, this is such a complex disorder that no two patients are the same. Patients often with migraines have a set of triggers. Those triggers can change as they go through their lives, and the triggers are not necessarily the same between patients. I can provide people with a list of common triggers, which are things like aged cheeses, cured meats, tannins in wine and fermentation, so beer and things like that. Chocolate, caffeine for some patients is a trigger, caffeine for other patients is a treatment, right? So I can provide patients with a list of commonly reported triggers. And when we go through that list, patients will say, okay, well, I have this one and this one. And then my other migraine patient won't have any of those, but they'll have another set, right, within that list. What I often say to patients is, okay, we want to consider our triggers. We want to keep a headache diary so that we can identify our triggers and then avoid them, right? But then, again, subjective, there are triggers that we all have that we can't control, right? So some of the questions that you pointed out, Shelby, hormones are a trigger. Some patients notice their migraines around their menstrual cycle because of the changes in hormones, or during or after pregnancy, or during or after menopause. Those are things we can't control, right? Weather changes, big trigger for a lot of people, okay? We cannot control the weather, right? So there are triggers that we can identify that for some of us will affect our migraines that we have control over. And those are things that we really want to keep in check. And then there are triggers that we can identify, but we can't do a whole lot about. So we just have to try to work around them and change our treatment regimen around them. And then there are the lifestyle components to this, right? So triggers are things that, okay, I know if I'm exposed to this, I will absolutely have a migraine. So if I eat cheese, I'm going to have a migraine, right? If, 2 days before my menstrual cycle, I'm going to have a migraine. Like, these are things that patients tell me. But then there are also lifestyle components, right? So, and these are the things that most doctors will tell you, right? Make sure you're getting 8 hours of sleep deprivation, big migraine trigger. Make sure you're staying hydrated. Dehydration, big trigger. Make sure you're eating regular meals, right? Because hunger, big trigger. And those are things that we do have control over, our lifestyle components, right? So when I talk to my patients about migraines, We talk about the objective component, the science behind it, the medications. We talk about the subjective component, which is what they feel, how their migraines behave. Do they have an aura? Do they not have an aura? How long their migraines typically last? What their triggers are and which of those we can avoid, and what their lifestyle is like and how we can modify that, right? A great example, my lifestyle as a physician who takes 72 hours of call, not great for migraines, right? Is that something that I can change right now? No. Is that something that is a part of most people's lifestyle? Probably not, right? So that is a unique challenge that I have to work around, right? And that I have to move, my medications around to accommodate that component of my lifestyle, right? So this is where it's really important for patients with this disorder to be mindful of their triggers and their lifestyle and how they can make adjustments to minimize the frequency, the intensity, and the likelihood of them having a migraine.
Thank you, Dr. Lowe. I think we're going to also be able to get into more specifics around some of the things that you were talking about in the Q&A portion. So over to you, Dr. Spiegel. What do you have to say about all this?
I'll start by saying that the strain and pain lies mainly in the brain. Dr. Lowe has elegantly described how a number of things can trigger a migraine, but a lot of them can be classified under the term stress, lack of sleep, too much work. So it's not just food and hormones, but also stress and how the body reacts to stress. And so there are things we can do about stress, and there's a science to how the brain reacts to stress and pain that we can mobilize to use to help us deal better with migraines. And so the kinds of things that happen with stress are increase in heart rate, blood pressure, and activation of what's called the salience network in the brain. It's the dorsal anterior cingulate cortex, the insula also, which are both part of not just the brain-body connection, but the pain network. And so migraines, which start deep in the trigeminal area and can be related to vascular as well as neurological events, can also be reacted to by the brain. So I guess what I'm going to be proposing to you is using the parts of your brain that aren't making you feel terrible, that can actually help make you feel better, even when a migraine is going on. And so what we've learned is that hypnosis, which is just a state of highly focused attention. If you ever had the sense of getting so caught up in a good movie that you forget you're watching a movie and enter the imagined world, how many of you have had that? Can you raise your hands here? Let us see. Thank you, Julie. That's a kind of self-hypnotic state. It's been called believed in imagination. And the brain filters in and out signals all the time that we are not so aware of. Right now, we'll do a little experiment. It looks like sitting down. You have sensations in the parts of your body touching the chairs that you're sitting in, but I'm hoping that not many of you were aware of those sensations until I brought it to your attention. If you were, you're bored, you can leave now. But most of the time, the brain is very good at filtering in and out, and it filters out hundreds of times more signals than we actually pay attention to and process. And so hypnosis can be mobilized to help alter your experience of pain. And I was at a party at the Stanford Medical School, a holiday party, and my wife Helen came over and said that one of our colleagues was having an acute migraine, and said, well, bring her over here. And so we're there with a lot of noise going around, and I sat her down in a corner. And she said, I'm going to have 3 terrible days. I know it. It's what always happens once a month, just as Dr. Lowe described, it usually happens. And her head was feeling hot. And often people with migraines feel heat. They get some vasodilatation in the scalp and the meninges potentially also. And I said, I want you to imagine right now that you've got a bag of ice on your head. And I just want you to concentrate on the sense of cool, tingling numbness. As she concentrated intently. And after a few minutes, she said, it's getting better. And what can happen when the migraine starts is you think, oh God, here I go. I'm going to be in bed for 3 days. I'm going to be miserable. And that just stresses you more. That just makes you feel even worse than you did before. And so what you can do is learn to interfere with the stress reaction that is amplifying the migraine physiology. And you wind up paying more attention to it instead of less. It's like the noisy kid in the classroom. So what I do is get people to enter a hypnotic state and imagine that they can react differently to what's going on in their brain and filter the hurt out of the pain. Imagine a competing sensation that makes you feel better rather than worse. And there are now 7 of 9 published studies looking at hypnosis, either delivered directly or remotely using an app like the Rewiring app that we have. And people, they find that 7 of 9 studies, randomized trials, show that hypnosis can actually reduce and sometimes eliminate the migraine pain. Because what's going on in your brain is not just the things that are stimulating the pain perception, but also the brain's decision how much attention to pay to it. We did a study with some Stanford undergraduates. We gave them electric shocks to their wrists. They were highly hypnotizable subjects. And in one condition, we just recorded the shocks, and you see big electrophysiological response, the P100, 200, and 300. So the first half a second after the signals come in. And we got the typical brainwave pattern that you see. And then we told them to imagine that they could filter the hurt out of the pain, that their arm was in ice water, cool, tingly, and numb. And it reduced by 50%, starting with a tenth of a second, the intensity of the pain signals being transmitted. So the brain is making decisions about what to pay attention to and what not. And that's a tool that we can use. And we find that actually, if you give people different instructions in hypnosis about how to react to pain signals like those shocks, if you tell them you literally will feel less pain, you can filter the hurt out of the pain, you get reduced activity in the somatosensory cortex, which is the primary sensory association area in the brain. If you tell them it's there, but it won't bother you, you get reduced activity in the dorsal part of the anterior cingulate cortex. The cingulate is like a C resting on its ends in the middle of the base of your brain. And the dorsal part is a keynote in the salience network. It's what tells you this is really something to worry about. This is terrible, or don't worry about it. It's fine. And when you told them that it's there, but it won't bother you, you got pain reduction instead in the anterior cingulate cortex. And in fact, when people go into a state of hypnosis, they reduce activity in that region of the brain, the dorsal anterior cingulate cortex. You just pay less attention. The more hypnotized you are, the less activity in that area. It's like the alarm system in the brain. It tells you whether to pay attention to something or not. So hypnosis can be instantly relaxing. And in fact, we find that people's ability to experience hypnosis is correlated with the levels of GABA aminobutyric acid. It's an inhibitory neurotransmitter that is a major component of activity in the anterior cingulate cortex. And to the extent that you're more hypnotizable, you have more of the GABA activity in that part of the brain. And that's the same activity that benzodiazepines, that anti-anxiety drugs trigger. So you've got your own little pharmacy there in the anterior cingulate in your brain, and you can use it to mute your brain's reaction to pain. So hypnosis can be a very effective tool in teaching you how to react differently to the possibility that you're having a migraine attack.
Well, I think also, just if we want to talk about the pathophys of this, one thing I didn't mention when I was going through the triggers, what you spoke to is stress, right? And the big, stress, of course, is a big trigger for migraines. This is one of the triggers that we don't have control over. But what more patients notice is it's the stress letdown that is actually the trigger. So patients will say, well, I got a migraine after my big examination, or I got a migraine after my big presentation, or I always get my migraines on the weekend after a really stressful week of work, right? Because when you're in that state of stress, all of those stress hormones are elevated, right? Your adrenaline, your cortisol. And if you think about it, stress hormones are designed to suppress pain because they're that fight or flight response, right? You're supposed to be running away from something that's going to kill you or fight something that's going to hurt you. And so you're not very sensitive to pain in that moment. But when you have those really high stress hormones and suddenly they drop because the stressor is gone, all of a sudden it's like a withdrawal, and all of that pain that it's been suppressing suddenly hits you at once. And that's what we call this stress letdown. And that we actually have it's a well-documented trigger for migraines. So the way I think this is really helpful is if you're starting to feel the stressor and that pain, and you enter this state of hypnosis, this calming state, that will likely, and again, this is just me hypothesizing here, reduce how much of those stress hormones, how high they get. And if they don't get as high, then you will have less of that withdrawal and therefore
Well,
less of that trigger.
I think that's true, but I would argue it a little bit differently because you're a neurologist and I'm a psychiatrist. So
Yes.
I tend to look more at brain defensive function, and I would reframe it just a bit and say that your brain was already doing some self-hypnosis during the stressor. It was saying, I've got to get through this, and I don't want you to be distracted by this discomfort that's building in your brain. And so the stress letdown is really saying, okay, you're not using your brain's ability to focus on one thing and put everything else out of conscious awareness. And you can do that without being under stress. You can do it by focusing in an unstressing way, the way we did it together.
Right.
So I'd say you've got the inflammatory or other activities that might stimulate discomfort in the brain, but you've got other parts of the brain trying to keep your attention away from that and focus on what you need to do. And then when you don't have to do that anymore, you may feel more of the headache, but the brain can still control it. And other parts of the brain that reduce stress levels, that literally express more gamma aminobutyric acid in the dorsal anterior cingulate, can help you relax and stay relaxed. And that's something that you just experienced, that you can just turn it off, turn it down.
Yeah, I like that phrase, turn it down. Turning down the stress response, I think it is key. And like I said earlier, stress is a trigger. It's a trigger that we all have. And it's something that most of the time we have very little control over. That's why it's stressful to begin with, right? That feeling of stress is often that lack of control. And so if you're able to turn down that stress response, that is your way of controlling this trigger in some way, even though the actual trigger itself you can't control, but you're controlling your reaction to it. And
That's
therefore,
exactly right.
Right? If you control your reaction to it, you get less of that spike, less of that withdrawal, less of that pain down the line. And so this is one of the things people say, well, what do I do about my stress? We all want to live a life where we have less stress, not just from a migraine perspective, but just in general and from a mental health perspective. So this, the benefits of being able to turn down that stress response and disconnect, are far reaching. It's not just migraine, it's not just pain, it's anxiety, depression, all, again, just general happiness. And again, as you have less pain, you have less of a trigger for the next migraine. And, that cycle ultimately over time will hopefully end up, reducing the frequency of your migraines overall.
Yes, and I think it will. And what you describe is exactly focusing on the thing you can control, which is how your body reacts to the stress that your brain is perceiving, and your brain can help you do that. So just as your brain can make you freak out and pay more attention to it, it can help you get your body comfortable, pay less attention to it. And that's why we built Reverie, so that anybody, anywhere, anytime can hear my mellifluous voice and help themselves float in a bath or like a hot tub, cool, tingling numbness in their head, filter their hurt out of the pain. And I welcome people to try it. You can have a free trial of it, and there's a special discount code, 30% off, to use Reverie anytime, anywhere you want. And we've had people who find that it really changes their lives. I know one of the questions is about how is hypnosis different from meditation? And I got a call from a lovely woman who said, I've been meditating for 10 years, twice a day for 10 years, experienced meditating. She said, I still have migraines. So I taught her what teaching you and what we have on Reverie, filter the hurt out of the pain. And she called me a week later and she said, Dr. Spiegel, my migraines are gone. Thank you. And I want to thank you for freeing me to use my intentionality. Because the premise in meditation is you don't intend to do anything. You're just open. You have open presence. You let thoughts and feelings flow through you. You don't fight them. You just let them happen. And that's a wonderful tradition. And many people find it very helpful, but it's more about being, and hypnosis is more about doing, using it to mobilize your brain to help you deal with stressors better and produce comfort where there is some discomfort. It's not just a stress management tool, although it is that, but also it's a pain management tool, and it can help with things like migraine.
Love it.
Thank you both. So we have a ton of pre-submitted questions, and I would love to get into it so we can hear more of each of your expertise. So lots of questions around hormones. You did touch on this before, but how are migraines related to hormones? Do you have a spiel on that?
Yes, I do. So the big one here is estrogen that we have found. So we've found that as estrogen drops, specifically, there is an increase in CGRP, which is an inflammatory neuropeptide that is critical in the pathophysiology of migraine. That's why some of the medications, the newer medications, actually block that molecule, the CGRP. So as estrogen drops, we have found that the frequency of migraines increases. So with this, obviously, particularly in women, we tend to see an increase in migraines during certain phases of the menstrual cycle, particularly right before the menstrual cycle. When that estrogen drops, we see that migraine comes on. Okay. Also, when different stages of pregnancy with the fluctuations of estrogen, particularly post-delivery, when estrogen drops, we will see an increase in migraine. Menopause is an interesting one in that initially patients may report that it worsens because there's that decline in estrogen, right? But then it stays stable. So it may initially worsen, but then it improves because you're not getting those big drops anymore, right? So the way I tell patients is, if it's high and it stays high, you tend to be okay. If it's low and it stays low, you tend to be okay. But it's the transition between the two that appears to be the issue. And so with that, there are things that we do depending, this is very patient specific. It also depends on the types of migraines that you have, where we will consider certain types of contraception for certain patients to help stabilize those estrogen levels. Now, that's not for everyone because, there's some contraindications, particularly with aura, stroke risk, estrogen and stroke risk. And so that, is a very in-depth conversation to be had with a patient and their physician, whether they're candidates and whether it helps. But the big culprit here, like I said, is estrogen. And there is actually some data with regards to testosterone, going to the other side of the coin here. Less so than estrogen, but we have seen some data coming out that suggests that low testosterone is associated with an increased risk of migraines in men, particularly chronic migraine. So, like I said, there's less data on that, but clearly hormones are going to play a part in this because, again, this is all connected, right? Hormones and pain, it should come as no surprise. But yes, the big one is going to be estrogen, and we do have treatment options, many of them focused on hormone replacement, oral contraceptives, things like that, if patients are candidates.
Are hormone-related migraines treated differently than others?
Yes, they can be. So we have different tiers of treatments. Okay, so if you have if you have estrogen-related migraines, it's what we call them, we will have some of the same medications. Well, all of the same medications are available to you, because if you have a hormone related migraine that is responsive to an abortive medication or an over the counter abortive medication, then why introduce additional hormones, right? The unique arm of the treatment approach to estrogen related migraines is, like I said, those combined contraception, right? That treatment is something that we don't offer to patients with non-estrogen related migraines, right? So the estrogen related migraine has all of these same treatment options as a regular migraine, plus the hormone option.
Somewhat related to hormones, perhaps. My son is 14 with chronic migraines. Will they improve after puberty?
That depends. So again, with a son, we tend to see more of a spike in testosterone as they hit puberty. And as I mentioned, there is some data to suggest that low testosterone levels are linked in some way to chronic migraine. So it is possible that as he enters puberty, that testosterone level will go up and stabilize, that there could be some improvement. But again, going back to what I said at the beginning, there's objective and subjective, right? So objectively, from a science standpoint, I would like to think that it's possible that it would improve as we see that testosterone rise and stabilize, but every patient is different. So I can't say for sure, but fingers crossed for him.
Definitely. Thank you. Let's talk about a couple other potential connections. Is there a connection between gut health and migraine?
That's a good one. I love that. Yes. So gut and brain
We like
are
that.
intimately connected, right? So gut health is very important when it comes to inflammation. And when you have bad gut health, you have a state of increased inflammation. That increased inflammation is going to lower that threshold for migraines and just a whole other slew of issues that are linked to inflammation in general, right? And so this is why when we talk about triggers for migraines and we talk about dietary triggers, there are things that are in that diet that just they are a trigger for you because they have tannins in them or they're fermented. That's one component of looking at the gut aspect. But then the other component is even if you're avoiding your clearly documented triggers, if you're eating really inflammatory things or things that disrupt your, gut microbiome, that puts your body into kind of this increased inflammatory state in general. And if you're already inflamed, your likelihood of having a migraine is going to be higher than if you are not in a state of constant inflammation, right? So there's a lot of data coming out about this, just the gut brain axis in general. There's quite a bit of data focusing on that for multiple neurologic conditions. But with migraine in particular, the big one is the inflammatory response that you see as your gut microbiome is disrupted.
Okay. Well, and on that note about triggers, can migraine be reversed by controlling the trigger permanently?
So to say reverse is a little difficult. If you are a person that your pathophysiology, you have a network where one thing triggers the next, which triggers the next, which predisposes you to migraine, that network is likely going to exist indefinitely. But if you are avoiding the trigger that is step one of activating that network, then you can avoid your migraine, right? But in terms of reversing it, it's not something that we can say either you have it or you don't. You can activate it or reverse it, if that makes sense. But trigger avoidance is key. And I do have patients that, have a history of migraines, but haven't had migraines for 6 months, 1 year, because they have very well documented triggers that they are very on top of. So trigger avoidance can help control your migraines. It's a big part, it's step one in the treatment algorithm. Lifestyle changes and trigger avoidance. And some patients are lucky enough that those two things together is enough to control their migraines such that they don't need medication, right? But again, because there is that complex pathway in those patients, that's not enough. It doesn't mean we say, hey, we stop doing that. We keep doing the trigger avoidance and then add on medication as needed. So it's not really reversing the pathophysiology. It's already in there, but it would be key in controlling your migraine.
I'd say it's not just trigger avoidance, but trigger response. So if you can catch it
Yeah.
early when you feel the trigger starting to happen, you have a better chance of controlling the rest of your brain's reaction to the pain stimulus. And we know in hypnosis that you enhance your connectivity between the prefrontal cortex, our executive control network, and the insula, which is a key node in the pain network, and is part of how you control how your body reacts to stimuli. One other thing I'd mentioned, there was a question that somebody asked about why there's hypnosis for gut problems as well, for irritable bowel syndrome and so on. And it works. It's been proven in a number of randomized trials. And yet it is not still the go-to treatment. And that's one reason that we built Rewiring, is to make it available to anybody who wants to try it and see if it can work, because it can be very helpful in dealing with a number of these stress-mediated disorders, gut and brain as well.
Yes. What is the best thing to do when a migraine is coming on?
Turn on Rewiring and get your brain cool, tingling, and numb. The nice thing is it's right there. I mean, it's actually quicker than medications because you don't need to fill a prescription and see what happens. We've got evidence among thousands of our users that 4 out of 5 of them get immediate pain relief within 10 minutes. And so try that first. There are no side effects, and it's available to you anywhere, anytime you want to use it.
We also have questions regarding other forms of treatment that are, I don't know how popular they are. What do you think about Botox for migraine?
So Botox is FDA approved for chronic migraine. So patients do have some success, they have quite a bit of success actually with it. You have multiple injections about the head, back of the head, and also the neck musculature here. And it is going to prevent transmission of those pain signals in the sensory nerves right under the scalp. It also is going to reduce a lot of that muscle tension in the back here, which can also be a trigger, because what happened? Why do we have muscle tension in our neck and shoulders? Because we're stressed, right? So we target that as well. And patients have great success with it. Now, there are patients where Botox is all they need. They get their Botox for their chronic migraine and they're good to go. And then there are patients that more often than not, they're having their Botox regularly for their chronic migraine. And then they also have their abortive medication if they happen to have a particularly bad day and they need to, take something as they feel that migraine coming on.
I just want to add that it isn't either or. That one of the nice things is you can try a number of these things, and that's what Dr. Lowe does in her practice, and that's what I do too.
Yeah.
The nice thing is you can try the self-hypnosis. If it works, great. If it doesn't, or if it supplements the other treatments that you're using, great. But you don't have to make a choice, one or the other. Try them both.
Absolutely. And like I said earlier, the first treatment approach is lifestyle change, or let me back up. The first step in treatment of migraine is what we call headache hygiene. Headache hygiene is composed of trigger avoidance and lifestyle change. Okay. And like I said, if you can control your migraines with headache hygiene, fantastic, right? Why subject yourself to having to take a medication, the cost associated with that, the particular side effects associated with that, right? If you can control it with headache hygiene, and perhaps this is where we can talk about hypnosis, we put that in our headache hygiene regimen, right? So this is something that we're doing. And if just how for my patients where they say, okay, headache hygiene ain't cutting it, then okay, we tackle on medicine. But like I said, that doesn't mean we stop doing the headache hygiene.
Right.
We still have to do the headache hygiene, but now we also just need something to help us because we have to function in society. And in the event that the headache hygiene isn't enough or isn't sufficient for us, we have to have a backup plan, right? So it is definitely a multi-faceted approach here with medications as well as lifestyle modification. And that's where things like this, where our reaction to stress, really fits in and can be very helpful.
Just an easy way to remember it is 3 H's: headache, hygiene, and hypnosis.
That's great. Thank you both. We ran over time a little bit. Sorry about that. We had so many more questions too, and unfortunately we weren't able to get to all of them, but I really appreciate both of you sharing your expertise. And we're sharing links to where everyone can find more about both of you and your work so that they can continue to learn about these different protocols and methods for managing their migraines. So hopefully everyone here will find something that works well for them.
There's a really nice comment from Kaylee here. I've practiced the pain hypnosis nearly daily for some time. It's now integrated to my sense of well-being. There is no calm like it. Terrific.
I love that.
Thank you, Kaylee. Yes.
That's beautiful. Thank you, Dr. Lowe, so much for sharing your expertise. And I'm linking everybody to your social channels so they can continue to learn more.
Thank you.
Thank you. Thank you, Dr. Lowe. Thanks for joining us.
Thank you. Take care. Bye-bye.